Cardiopulmonary resuscitation, CPR, saving lives in cardiac arrest. Expanded lecture note. Welcome to our CPR lecture series. Cardiopulmonary resuscitation is a life-saving technique that's crucial in emergency situations like cardiac arrest. In this video, we'll explore the fundamentals of CPR, including its importance, techniques, and best practices. Whether you're a healthcare professional or a concerned citizen, this presentation will equip you with the knowledge and skills to respond confidently in a cardiac emergency. Let's get started and learn how to save lives. Case scenario: when no one knows what to do. 1. A 38-year-old man suddenly collapses while playing a football match in a small village park. 2. The crowd rushes around him, and he is found unconscious, not breathing, and has no pulse. 3. People in the crowd attempt to help by fanning him and sprinkling water on his face. Some bystanders believe he is possessed, or just fainted. 4. No one in the crowd attempts chest compressions or CPR because they are unfamiliar with the technique. 5. Minute pass while waiting for transportation to the nearest clinic. By the time he arrives at the clinic, it is too late to save him. 6. Health workers later explain that immediate CPR could have kept his brain and heart alive until advanced medical help arrived. Introduction. 1. CPR saves lives. It keeps blood and oxygen flowing to vital organs during cardiac arrest. 2. Immediate action matters. Survival chances drop by 7–10% for every minute without CPR. 3. Anyone can do it. CPR is not just for doctors. With basic training, anyone can help. 4. Simple steps, big impact. Chest compressions and rescue breaths can double or triple survival rates. 5. Global importance. CPR is a life-saving skill everyone should learn, anywhere, anytime. Definition. 1. Cardiopulmonary resuscitation, CPR, is a life-saving emergency procedure that combines chest compressions and artificial ventilation to maintain circulatory flow and oxygenation during cardiac arrest or severe respiratory failure until spontaneous circulation and breathing are restored. Or 2. According to the American Heart Association (AHA), CPR is an emergency procedure combining chest compressions with or without ventilation to maintain circulation and oxygenation during cardiac arrest. Objectives. 1. Preserve brain function by maintaining oxygen delivery to the central nervous system. 2. Sustain circulation of blood to vital organs during cardiac arrest. 3. Maintain oxygenation through artificial ventilation and chest compressions. 4. Bridge the gap until advanced life support and definitive treatment are available. 5. Improve survival outcomes by increasing the chance of return of spontaneous circulation, ROSC. Historical background. 1. 1960. Modern CPR developed, chest compressions plus ventilation. 2. 1974. American Heart Association (AHA) adopted CPR guidelines. 3. Continuous updates VIST AHA and ERC Guidelines 2020-2021. Pathophysiology of cardiac arrest. 1. Cessation of effective cardiac output leading to the heart stops pumping blood effectively due to arrhythmia (VF), pulseless VT asystole, or severe bradycardia (P. 2. Abrupt loss of cerebral perfusion leading to unconsciousness occurs within 5 to 10 seconds. 3. Respiratory arrest follows leading to within 1 minute, leading to hypoxemia and acidosis. 4. Cellular ischemia leading to lack of oxygen and nutrients causes shift to anaerobic metabolism, lactic acidosis, and ATP depletion, ATP loss. 5. Multi-organ failure progression leading to irreversible brain damage within 4 to 6 minutes, followed by deterioration of other vital organs if circulation is not restored. Indications for CPR. 1. Cardiac arrest, sudden cessation of effective heartbeat asystole, VF, pulseless VT, P. 2. Respiratory arrest, absence of breathing with impending cardiac standstill. 3. Severe arrhythmias, leading to collapse, pulselessness, or ineffective circulation. 4. Unresponsiveness with no pulse, patient unconscious, apneic, and pulseless. 5. Sudden collapse in hospital or community, e.g., trauma, drowning, electrocution, drug overdose. Contraindications for CPR. 1. Signs of irreversible death, rigor mortis, dependent lividity, decapitation, decomposition. 2. Established do not resuscitate, DNR, order, legal ethical directive against resuscitation. 3. End-stage terminal illness, where CPR would not change prognosis or quality of life. 4. Prolonged cardiac arrest without response, no circulation after adequate resuscitative effort. 5. Severe trauma incompatible with life, e.g., of head injury, exsanguination. The chain of survival. 1. Early recognition and call for help, activate emergency response system. 2. Early high-quality CPR, minimizes circulatory arrest time. 3. Rapid defibrillation, within 3 to 5 minutes in VF-VT. 4. Advanced life support, ACLS, airway, drugs, monitoring. 5. Post-resuscitation care, ICU, targeted temperature management, hemodynamic optimization. Basic life support, BLS. Adult. 1. Ensure scene safety, check surroundings for hazards before approaching the patient. 2. Check responsiveness, tap and shout, "Are you okay?" 3. Call for help, activate emergency response system and request an AED defibrillator. 4. Check pulse and breathing simultaneously, is less than or equal to 10 seconds, assess carotid pulse and chest movement. 5. If no pulse and no normal breathing, start CPR immediately. High-quality CPR, adult. 1. Position, patient on firm, flat surface. 2. Chest compressions. 1. Rate, 100 to 120 per minute. 2. Depth, 5 to 6 cm, 2-2.5 inches. 3. Full chest recoil after each compression. 4. Minimize interruptions, less than 10 seconds. High-quality CPR, adult. Ventilations. 1. Ratio, 30 compressions, 2 breaths, if trained and able. 2. Each breath, approximately 1 second, enough to see chest rise. 3. If no rescue breaths possible, right pointing arrow hands only CPR. Defibrillation. AED use. 1. Turn on AED as soon as available. 2. Follow prompts. Attach pads. Analyze rhythm, shock if advised. 3. Resume CPR immediately after shock or no shock advised. Continue until 1. Patient shows signs of life, movement, breathing, pulse. 2. Advanced help takes over. 3. You are too exhausted to continue. Pediatric BLS. 1. Compression ventilation ratio. 1. 1 rescuer, 30, 2. 2. 2 rescuers, 15, 2. 2. Compression depth, 1/3 chest diameter, approximately 5 cm child, 4 cm infant. 3. Preferred pulse check, brachial infants, carotid, femoral children. Advanced cardiac life support, ACLS. 1. Airway and breathing. 2. Advanced airway, endotracheal intubation or supraglottic device. 3. Oxygen, 100% FiO2. 4. Waveform capnography to confirm tube placement, ETCO2. More than 10 mm of mercury suggests effective CPR. Circulation. 1. IV/IO access for medications. 2. Drugs. 1. Epinephrine 1 mg IV every 3-5 minutes, all arrest rhythms. 2. Amiodarone 300 mg IV, for refractory VF, pulseless VT. 3. Lidocaine alternative if amiodarone unavailable. Defibrillation. 1. Biphasic shock. 120 to 200 J. This type of defibrillator delivers a biphasic waveform, which is more effective and requires lower energy levels. 2. Monophasic shock. 360 J. This type of defibrillator delivers a monophasic waveform, which requires a standard, higher energy level. Reversible causes. H's and T's. H's. 1. Hypovolemia. 2. Hypoxia. 3. Hydrogen ion acidosis. 4. Hyperkalemia. 5. Hypothermia. 6. Hypoglycemia. T's. 1. Tension pneumothorax. 2. Tamponade cardiac. 3. Toxins. 4. Thrombosis pulmonary. 5. Thrombosis coronary. 6. Trauma. Post-resuscitation care. 1. Stabilize circulation. Maintain adequate blood pressure and perfusion, use fluids, vasopressors if needed. 2. Optimize oxygenation and ventilation. Target SpO2, 94-98%. Avoid both hypoxia and hyperoxia. Maintain normocapnia. 3. Protect the brain. Consider targeted temperature management, TTM 32 to 36 degrees Celsius for 24 hours if comatose after ROSC. 4. Continuous monitoring, ECG, blood pressure, oxygen saturation, end-tidal CO2, urine output. 5. Identify and treat the cause, e.g., acute coronary syndrome, electrolyte imbalance, arrhythmias, trauma, sepsis. 6. Prevent recurrence, antiarrhythmics, coronary reperfusion, PCI, thrombolysis, correction of metabolic derangements. 7. ICU admission, for advanced support and neurological evaluation. 8. Multidisciplinary care, involvement of cardiology, critical care, neurology, and rehabilitation teams. Special situations. Drowning. 1. Prioritize rescue breathing. Hypoxia is the primary problem due to lack of oxygen. 2. Start with 5 initial rescue breaths before compressions to address severe oxygen deficiency. 3. Remove from water safely to prevent further injury to the victim or rescuer. 4. Dry chest quickly before AED use to ensure proper defibrillator function. Special situations. Hypothermia. 1. Check pulse for up to 60 seconds. Slow heart rate may be missed due to hypothermia's effects on cardiac function. 2. Begin CPR if no signs of life. Hypothermic patients may appear lifeless but still be salvageable. 3. Defibrillation and drugs may be less effective until core temp and GT, 30 degrees Celsius. Hypothermia reduces responsiveness to standard interventions. 4. Rewarm gradually. External and internal rewarming methods are used to safely restore core temperature and prevent further complications. Special situations. Electrocution. 1. Ensure scene safety. Switch off power first to prevent further electrocution to both the victim and rescuer. 2. Treat cardiac arrest like VF, VT. Early defibrillation is key as electrical shock can cause fatal arrhythmias. 3. Look for entry-exit burns and associated trauma. Electrical injuries can cause internal damage and external signs may not reflect the severity. Special situations. Asthma, anaphylaxis. 1. May present as P or asphyxial arrest. Severe bronchospasm or airway obstruction can lead to cardiac arrest. 2. Ensure airway and ventilation with oxygen. Adequate oxygenation is crucial to prevent further deterioration. 3. Use adrenaline promptly in anaphylaxis. Adrenaline is a key treatment for anaphylactic reactions. helping to relax airway muscles and improve circulation. 4. Consider reversible bronchospasm treatment. Nebulizers and IV drugs can help relax airway muscles and improve ventilation. Special situations. Trauma. 1. Control airway and bleeding immediately. Securing the airway and stopping bleeding are critical to prevent hypoxia and hemorrhagic shock. 2. Prioritize cervical spine protection during airway maneuvers. Spinal injury is common in trauma patients, and improper movement can worsen the injury. 3. Chest decompression for tension pneumothorax tamponade. Relieving pressure in the chest can restore cardiac output and improve ventilation. 4. Massive hemorrhage may require damage control resuscitation. Limiting fluid resuscitation and controlling bleeding surgically can help prevent further complications. Special situations. Pregnancy. 1. Displace uterus leftward. Manual or wedge displacement relieves aortocaval compression, improving blood flow to the mother and fetus. 2. Standard CPR, but chest compressions may be less effective. Aortocaval compression can reduce the effectiveness of CPR in pregnant women. 3. Prepare for perimortem cesarean delivery if ROSC not achieved within 4 to 5 minutes. Prompt delivery may improve maternal and fetal outcomes if resuscitation is unsuccessful. Special situations. Poisoning, overdose. 1. Arrest often due to respiratory depression or arrhythmia. Substances can impair breathing or disrupt heart rhythm, leading to cardiac arrest. 2. Give specific antidotes where available. Antidotes like naloxone for opioids can rapidly reverse life-threatening effects. 3. Avoid mouth-to-mouth if risk of contamination. Rescuers should prioritize their safety to prevent exposure to toxic substances. Complications of CPR. 1. Rib and sternal fractures. Common injuries due to chest compressions, especially in older adults or those with osteoporosis. 2. Gastric insufflation and aspiration. Air entering the stomach during ventilation can lead to regurgitation and aspiration of stomach contents. 3. Internal organ injury. Liver and spleen injuries can occur due to forceful compressions or improper technique. 4. Brain injury due to prolonged hypoxia. Inadequate blood flow and oxygenation can cause permanent brain damage if circulation is not restored promptly. 5. Stroke. Embolic events can occur due to fractured ribs or thrombi dislodged during CPR. 6. Hematomas. Chest wall or abdominal wall hematomas can develop due to trauma from compressions. 7. Soft tissue injuries. Bruising and abrasions are common due to the physical nature of CPR. Outcomes and prognosis of CPR. Key facts. 1. Survival rates are generally low. Overall survival to hospital discharge after out-of-hospital cardiac arrest is approximately 10 to 12%. 2. In-hospital cardiac arrest survival is better, around 20 to 25%, depending on patient factors and cause. 3. Time is critical. Survival decreases by 7–10% for every minute delay in CPR or defibrillation. 4. Early defibrillation matters. In ventricular fibrillation (VF) or pulse VT, immediate shock can yield survival rates more than 50 to 70% if delivered within 3 to 5 minutes. 5. Neurological outcomes vary. Only about 8–10% of out-of-hospital arrests result in good neurological recovery. 6. Underlying cause determines prognosis. Arrests due to reversible causes, e.g., arrhythmia, hypoxia, electrolyte imbalance, have better outcomes than massive trauma or sepsis. 7. Age and comorbidities impact survival. Elderly patients and those with advanced chronic disease often have worse outcomes. 8. Post-resuscitation care improves prognosis. Targeted temperature management, reperfusion therapy, and ICU-level support significantly improve neurological survival. 9. Most survivors have some disability, but a significant proportion can return to baseline function if resuscitation is timely and care is optimal. 10. Global survival variation. Outcomes differ by region, emergency response systems, and public CPR training. Conclusions on CPR. 1. CPR is a life-saving emergency skill that maintains circulation and oxygenation during cardiac arrest. 2. Early recognition and prompt action greatly improve survival chances. 3. Defibrillation is critical for shockable VF pulseless VT, and should be done as soon as possible. 4. High-quality chest compressions with minimal interruptions are the foundation of effective CPR. Ventilation support is important, but chest compressions take priority if rescuers are untrained. 6. Post-resuscitation care, oxygenation, hemodynamic stability, neuroprotection is vital for meaningful recovery. 7. Wider public training in BS can significantly increase survival rates worldwide. 8. CPR has limitations. Prognosis depends on time to intervention, underlying cause, comorbidities, and quality of care. 9. Every minute counts. CPR bridges the gap until advanced life support and definitive treatment are available. 10. Anyone can save a life. Spreading CPR knowledge empowers communities and reduces preventable deaths. References. 1. American Heart Association Guidelines for CPR and ECC, 2020-2021. 2. European Resuscitation Council Guidelines, 2021. 3. Miller's Anesthesia, 9th edition. 4. TLS Manual, 10th edition. Thank you for watching. If you liked this content, don't forget to like to show your support. Comment and share your thoughts. Share with your friends and family. Subscribe for more exciting content. Your engagement means the world to us. Stay tuned for more.